Hello. Hello, everyone. Um, See if I can get it to work in the proper window here. There we go. All right. So my name is Mellitus. It looks like some of you had a little bit trouble with the audio version of this presentation on the NAPLEX review for diabetes mellitus. Um, so I'm going to um, make this an audio version for you all. I will keep the other version as well, so you guys can use it as a reference. If you don't want to listen to the audio, that's fine. Um, the illustrations and the descriptions, it should pretty much tell you everything about um, this presentation. For some of you, I think the audio works better, so I will play it here for you all. So some of you probably already looked at this. Um, be sure that you're familiar with all the endocrinology topics listed here because any of these um, topics could be on the NAPLEX exam. So I just wanted to post it here for your reference. Be sure to know what drugs are used in each of these different disease states that's covered in the endocrinology section of the NAPLEX because they could ask a question on that. And also, it's important to know, especially when you're in practice, helping patients and all. There's different disorders. Some of these disorders do overlap in terms of the medications. So it's important to know the similar types of meds too that can be used in multiple different diseases. So know that as well. In this case, we're just going to talk about the diabetes medication specifically and the mechanisms. So before we start, diabetes essentially is where it comes as two types. You got type 1 and type 2. Type 1 is basically when the pancreas is definitely unable to make any type of basically it's not able to produce any insulin at all. And so that's where type 1 happens. Typically, it's like there's a beta cell loss, macrophages, T cells, cytokines, that kind of stuff. But the overall bottom line is here is that the type 1 in type 1 diabetes, there is basically no insulin being produced. And so without insulin, glucose builds up in the blood and the sugar levels go up. And so this is where patients would typically just use insulin, have to use insulin mainly to decrease the blood sugar levels. In type 2, patients are able to produce, or the pancreas is able to produce the insulin, but it's just not working correctly as it should. So essentially, that's the difference between these two types. One is where the pancreas is not producing insulin at all. The second type 2 is where the pancreas is making insulin, but it's just not working correctly or as it normally should. But in both cases, there's a beta cell loss. there is definitely going to be increased level of blood sugar in the blood. And so that's how diabetes would occur. Um, in this case, I do want you to note the differences here. Type 1 is the absolute insulin deficiency, and type 2 is the relative insulin deficiency. So those are the differences here. And you can also see other things that happen, especially in type 2, where there is hyperlipidemia, inflammatory cytokines, amyloid accumulation. So it gets pretty messy. So let's see about the treatment. So type 1 can be treated through insulin replacement, which is what we just talked about. Type 2 can be treated with lifestyle and oral injectable anti-diabetic agents. And we're going to talk a little bit about these. I'm sure some of you have seen them in practice, like GLP-1 agonists, Ozempic, Mounjaro, and some other types like metformin, glipizide, glyburide, all those sulfonylureas as well. So we'll go over some of these medication mechanisms, and if there's anything that I'm missing, feel free to comment or let me know so I can post a new presentation on this. There are always new types of medications that's coming out, and it is important for everyone to know about these so that they can be used correctly, especially in practice setting. So I hope this will be helpful to you all as well. So feel free to also let us know if you have any questions. So in terms of treatments, these are the basic treatments for diabetes. Insulin, big one like metformin, sulfonylureas like glipizide, glyburide, or glimepiride, meglitinides, diazolidiones, diazolidinediones, which are the TZDs such as like pioglitazone and then rosiglitazone. Then you got DPP-4 inhibitors, GLP-1 agonists, SGLT2 SGLT. I put SGLT1 inhibitor with SGLT. Should be SGLT2 inhibitors. And then the alpha glucosidase inhibitors and the amylin analog. So analog is interesting because it's actually going to work mostly in the brain here. The medication typically here is pramlintide. When patient takes it, it's going to bind to the amylin receptor and activate neural signaling in the body so that it slows the gastric emptying and prevent post-meal glucagon release and increase satiety or fullness. So the glucagon is typically, released by the, when it's released, you can see how in this example, you could see the pancreas, and you could see the pancreas beta cells, but there's also pancreas alpha cell as well, like an alpha receptor and a beta receptor. You're going to see later in this in the slides how GLP-1 agonists are going to play a role in both types of receptors. But in this case, like I said, like it says here, you got pancreatic alpha cells. It decreases the glucagon release. That's where the glucagon gets released. Pancreatic beta cells is the other part of it. So just note those differences here because it's important to know like the difference here between the different alpha and beta cells, especially when it comes to the GLP-1 agonists. Um, so you'll see that in the later slides. Then there are different types of insulin types. Specifically, these are for patients that are type 1 diabetic and they would require insulin specifically. But there's different types. You have a long-acting basal insulin, glargine, detamir, degludec. Um, and this one maintains background insulin throughout the day and night. The bolus is the fast-acting. These are lispro, aspart, glulisine. Then the intermediate, which is the Humulin N, Novolin N, and the short acting, which is the Humulin R and Novolin R. Just wanted to let you know that you might see this N. Just understand N is intermediate. Regular is short acting. Regular insulin is typically what patients would get when they are in hospital. And then there's it's a regular insulin is typically what's given as IV. So, so something like Humulin R or Novolin R is given. I do want to list here in reference. This might be different from what you all see. 1 unit of rapid acting insulin covers 12 to 15 grams of carbohydrates on average. So I do want to note that sometimes patients have low blood sugar, and I don't know if it has changed or not, but when patient gets less than 70 or has less than 70 glucose levels, then they are going to start getting those hypoglycemic symptoms. So in that case, they would require 15 grams of carbs. So it's to bring it up to normal levels. It's something that you should be familiar and counsel your patients about when it comes to helping them with their sugar levels, and also just keep that in mind. This is a table for your reference, so you can use it and feel free to use it as a study tool as well. So let's look at the insulin mechanism. Insulin typically will be released by the pancreas, but also when a medication is taken. And when the insulin triggers the transmembrane tyrosine kinase inhibitor, that's going to be this receptor here, and then the GLUT4 that's in the muscle or fat is going to raise up to the surface and then take the glucose inside. So first it activates this switch in order to activate this other switch. And then that glucose gets used for like energy, for protein synthesis, fat synthesis, all those kinds of things. And then there's these other enzymes that's going to react, when it's taken, and then start the metabolic processes. So I do want to mention this here, just to show you a little bit in the picture, how the insulin will actually trigger the release of the other receptor to the surface. This receptor is typically produced within the muscle and fat, and then it just gets risen to the surface to collect the glucose. And then the metformin is another one. Metformin enters the liver cells, and then within the cells, it basically disrupts the mitochondrial electron transport chain in the liver cell. So it's going to decrease the ATP and increase the AMP, and then activate the AMPK, which is the AMP protein kinase inhibitor. It's going to turn off the energy consuming processes like gluconeogenesis and lipogenesis and turn on the fatty acid oxidation. So overall, it's going to increase the insulin sensitivity and decrease the lipogenesis. And so you could see here in the picture, metformin is typically just working within the liver cell here and then causing all of these processes, or this is how making all these processes work so that there's increased insulin sensitivity this way. The overall net effect is going to decrease the glucose production, so that's good. Now, sometimes patients have like stomach upset when they're taking metformin and all. You know, it's just a very common side effect, and the body might not be used to this type of medication when it's taken, especially when it's, you know, a new medication, and might lead to some side effects like, you know, GI upset and all of that. So at that point, you know, maybe advising some patients, you know, try taking it with food. It will kind of minimize some of the upset stomach and the GI effects. And so it's important to counsel patients prior to using these types of medications so that they understand the overall importance on its use as well, and to mitigate these side effects. So counseling is very important. So be sure to pay attention to the counseling points, consultations, and you know, teaching the patients and having them teach you back what they know about the medication. Also, seeing what their doctor told them about that medication. So it's important to know all that. This next one is basically like pure glutathione, and enters the cell. Again, kind of like muscle and liver. And then it binds to the inside part of the cell, which is where like the DNA and those processes occur within the nucleus, and then it's going to increase that insulin sensitivity. So it's going to affect the processes within the cell of the muscle or liver tissue within the nucleus of that cell, and then you know, change the gene transcription this way to allow increased insulin sensitivity. That's what this class of medication TZD works, basically. So these are just basic mechanistic concepts, because I don't want you guys being overwhelmed with so many mechanistic steps here, because this is review for the exam. This isn't like you're going to be experts in every single medication here, but at least having some general idea of how the medication works is important. So in this case, this is a PPAR gamma receptor that the pioglitazone binds. It's going to alter gene transcription. At least having an understanding of those basic lines of you know, mechanism for this TZD will get you an answer correct on the test. You have to at least have the basic knowledge on this. Just like the metformin, you know, understanding that where it works, like in the liver. You don't have to know specifically like activates AMPK and all of that, but at least having some general idea is going to kind of give you a picture as to how it works. Um, and then the insulin mechanism as well. At least the GLUT4, you can see how that kind of goes to a surface there and then helps with taking the glucose. Once insulin is triggers this transmembrane tyrosine kinase, then you could see that the GLUT4s can go up to the surface. Without an insulin binding, it's not going to do anything. So the insulin is very important in this case. So this general idea of the mechanism is very important, especially when it comes to insulin sensitivity, insulin getting released by the pancreas, and then working on different parts of the body to reduce the overall glucose. So this next one is on DPP4 inhibitors. It is basically a way when patients taking something like eating something like pizza or something like ice cream or something, food gets broken down in the gut through an enzyme called incretins. It gets broken up into different parts. You got a GLP-1 and a GIP, and these actually get bound to the pancreas, and then it will go ahead and secrete and it will be secreted in the intestines and it's going to prevent, and give me 1 second on this mechanism because I know this can be a little confusing to some of you. Just give me a second here. We want to make sure that you get this right. So So it's a little bit different here because the DPP4 is actually going to slow down the process of breaking up incretins in this case. So, like, there might be some incretins getting broken up in the process. You can see here in this diagram that after a meal, the GLP and GIP1, GLP1 and GIP are secreted from the intestine. The DPP4 inhibitors prevent their breakdown so incretins can stay longer. And eventually they'll get broken up. They are going to bind to these receptors on the pancreas, and then insulin is going to be released, but it's not going to be overwhelmed. So, because incretins are going to stimulate the insulin release from beta cells and increase the glucose dependent insulin secretion. So yes, and then incretins also suppress the glucagon release from alpha cells. Since I made this recording earlier, some of this information was, seemed like it was not correct. So I had to look it up for a little bit for you all so you guys can get the most accurate information on this. Um, so so in this case, incretins suppress the glucagon release from the alpha cells and they slow the gastric emptying. So this is pretty good. You know, the DPP4 inhibitors can help kind of slow down the process of the insulin release from the pancreas. Now, feel free to let me know if there is something that you're confused about. I'll look more into it. But this seems like what is occurring in the process. Of course, the incretins are very important in the process of insulin release, but there could be some misunderstandings here. So I just want to let you know. Um, so hopefully that kind of helps you out. Um, Another thing is, I think the DPP4 here is preventing the breakdown of incretins. So, into the two parts here, GLP-1 and GIP. So this medication, and I just saw this, is the sitagliptin, one of the medications with the inhibitor, is going to block the DPP4 enzyme that's responsible for blocking the actions of incretins from breaking down into these two components. And that's supposed to bind to a pancreas for insulin release. So I think that's what's occurring here. And if anyone has any trouble with this, just let me know. We can work together a solution on this. So the GLP-1 receptor agonist mechanism, we talked a little bit about this earlier. There's an alpha and the beta cells here. So there are two types here. The beta cells increase insulin synthesis, and the alpha cells decrease the glucagon production when this Ozempic binds to it. That's essentially what's occurring here. And in the alpha glucosidase inhibitor mechanism, this one is actually going to bind within the intestine the alpha glucosidase enzyme. So it's going to prevent the breakdown of the carbohydrates so it won't get reabsorbed and turn into absorbable monosaccharides and then increase the blood sugar. So it's going to slow down the absorption of the carbohydrates this way. And that's pretty much it. Does anyone have any questions so far on this presentation? I know that one of the slides might have been a little bit confusing to you, so I just wanted to help clear it up. But if you guys have any questions on any of this content, feel free to let me know. I find some of these slides a little bit, uh, you know, less informative. So we'll try to add more content for you all so you guys can get better at the mechanisms and all. And if any of you have any other questions, feel free to let me know. I mean, there's still information here, but I want to make sure that you guys get the quality amount here still for your exam. I'll also post some extra questions too for you guys so you guys can use that. So, all right. Well, thank you very much. I hope you all have a good day.